Hello everyone, I'm Dr. RMD. I'm pediatric resident at PGMR RML Hospital, New Delhi. This is the first video in the teaching series. This video can be applicable for UG students, that is MBBS students. It is also applicable for PG students for whom it is most necessary. It is also applicable for NEET PG aspirants, okay, and even NEET SS aspirants. So all the students can get benefit of this video. I'll try to minimize, but I'll also try not to cut down so much information so that it doesn't affect your preparation. So acute pancreatitis is one such disease where if you manage properly, okay, you can actually get good outcome. But if you don't manage properly, if you are not able to manage complications or you're not able to identify the complication, then it will become very difficult to manage acute pancreatitis patients. Acute pancreatitis has adult counterpart, okay, and pediatric and adult counterpart are so different. Like in adults will come with typical symptoms and diagnosis is so easy for acute pancreatitis, but in pediatrics it is not the case. Like in first 1 year of till 1 year of age, acute pancreatitis is often missed, okay. You won't be seeing many cases of acute pancreatitis also. As the age advances, the typical features of pancreatitis comes into picture. That's why it is very necessary for a pediatrician to identify acute pancreatitis and manage accordingly, because it is, if identified early and treated properly, and if the complications are managed, then it is a very easy it's a cup of cake. It's not that difficult, okay. So here acute pancreatitis definition is so simple, like it is inflammation of pancreas. But according to Inspire, okay, according to Inspire is a clinical group, okay, that conducted extensive studies on pediatric patients. So it stands for International Society for Pediatric Pancreatitis in Search of Cure, okay. So they have defined pancreatitis according to their criteria, where 2 out of 3 criteria should be available to diagnose as acute pancreatitis, which we'll be seeing in the later part of the video, where we'll be seeing the diagnostic approach to acute pancreatitis. Now, one thing which you should note is acute recurrent pancreatitis, okay. Acute recurrent pancreatitis is more than or 2 episodes of acute pancreatitis with the normal level of enzymes in between. Okay, so enzymes should normalize in between, and if there are 2 or more episodes of acute pancreatitis, then we call it as acute recurrent pancreatitis. And if the pancreatitis inflammation goes on for a long time with fibrosis and all, then we name it as chronic pancreatitis, okay. So how do we assess severity of pancreatitis, whether it is mild pancreatitis or whether it is moderate or whether it is severe? There is no separate grading or staging for that, and there is no separate approach for that. It is mainly based on clinical criteria only, okay. There is something called as CT severity index, but even that is also of limited help in managing these cases. So mild pancreatitis is, you will notice clinical feature, there will be elevated MLS lipase, but there will be no complications, okay, no complications, and child will recover within 1 week. There is nothing to be afraid of. There are no complications which develop. In moderate pancreatitis, moderate acute pancreatitis, there are within 48 hours there could be complication, but this complication resolve within 48 hours, okay. And in severe, there will be complication which persist more than 48 hours. There can be complications like shock, okay, and it may take more than 1 week for it to resolve also, okay. So this is the basic severity grading, okay. Now, most important thing, there are only 2 things in pancreatitis that you need to know. One is how to manage pancreatitis, and second thing is what is the etiology. The whole workup, the whole hallmark of acute pancreatitis and the following equally is based on 2 things. One is to manage a case of acute pancreatitis, and second is to identify the etiology. Etiological workup is the most essential, because that will decide whether the cause is like addressed or whether the patient will progress to recurrent pancreatitis. So basically in pediatric patients and adult patients, like in adult patients we have 2 common causes, that is alcohol, one, and second is gallstones. But in pediatric patients you won't see alcoholic pancreatitis, you also will see very rarely gallstone pancreatitis, okay. So that's in pediatric patient the spectrum shift towards the other end. That is, first is infections. Infections are one of the most common cause of pancreatitis in children. Second is trauma, okay. In fact, Nelson mentions in Western world trauma is the most common cause of pancreatitis. Third is drug induced pancreatitis. Fourth is systemic disorders that cause pancreatitis. Fifth is metabolic disorders. Sixth is neoplasia, okay. And seventh is miscellaneous causes, which includes mainly genetic. Nowadays, with the invention of whole exome sequencing and genetic studies, it is easy to identify genetic causes of pancreatitis. Also, we have anatomical defects, okay. And around 25% of the cases, their cause is not identified. We label it as idiopathic pancreatitis, okay, idiopathic recurrent pancreatitis. And then when we don't know the cause, the recurrence rate is high in this. Okay, now we'll be seeing in detail like each etiology, and we'll be seeing what actually causes pancreatitis in children. Okay, so first is infection. So anytime we get infection, we'll divide it as viral, bacterial, protozoal, etc. So in children, viral is the most common cause. Okay, viral, and one of the most important viruses is mumps. Okay, mumps is one of the most important, followed by influenza. You can have Coxsackie. Okay, you can have Hep A, Hep B. Okay, this can also cause, and there are many other viruses also. These are the most important ones to name. Okay, in mumps pancreatitis, one important thing to note is that in mumps, there is inflammation of salivary glands. So obviously amylase is going to increase, and lingual lipase is also going to increase. So this amylase lipase can be increased in 70% of the cases of mumps. Okay, but these 70% cases don't have pancreatitis. Okay, so in 70% of cases of mumps, there can be elevated amylase and lipase, but the patient doesn't need to have pancreatitis. That is one thing that you need to remember. Second, coming to bacterial, one more viral is HIV. Okay, HIV, will notice HIV causes pancreatitis in three ways. One is it can directly cause pancreatitis. Second, it can cause opportunistic infection. Okay, and opportunistic infection with CMV, with TB, with toxoplasma, all this can cause pancreatitis. And third is the drugs that we use. Two important drugs that we use. One is stavudine, other one is didanosine. These two are known to cause pancreatitis. Okay, so HIV is also one important cause. Bacterial causes, we have TB, we have brucella, okay, we have salmonella, okay, and we have 2-3 more other bacteria which are known to cause pancreatitis. Okay, and coming, even Shigella also causes. Okay, and enterohemorrhagic E. coli. These are the known causes. Okay, and we have protozoal, one important cause in Indian scenario, that is Ascariasis. These Ascariasis worms, they can go into this pancreatic duct, they can block pancreatic duct and cause pancreatic inflammation. Okay, so Ascariasis is one such condition which is known to cause pancreatitis. So this is related to infection. Second is coming to trauma. Okay, in trauma, most common is blunt trauma. Okay, and in Indian setting, the classic is cycle handle trauma. Okay, when the child is riding cycle and the cycle handle gets the blunt trauma because of cycle handle. So usually pancreas is a retroperitoneal organ, so damage to pancreas is very less. But when there is sharp blunt trauma, okay, deep blunt trauma, so that time it can cause pancreatitis, and this pancreatitis is because of pancreatic duct injury. So that's why whenever you are coming across a case of trauma where you are suspecting pancreatitis, always you have to order CCT abdomen to look for pancreatic duct. Okay, this is immediately required because this is a surgically treatable cause, and you should immediately intervene and repair pancreatic duct. Okay, remember this. This is for blunt trauma. Now there can be internal trauma. So for example, when ERCP is done, that is endoscopic. So ERCP, that is endoscopic retrograde cholangiopancreatography, okay, where we insert endoscope, that time also it can cause internal injury. Okay, this is also one more cause of pancreatitis secondary to internal trauma. Okay, next, coming to drugs. Which are the drugs? See, we make it a dictum. Okay, the dictum is whenever a patient with one, nephrotic syndrome, second, leukemia, third, whenever a patient with IBD, okay, and one more, okay, HIV. Okay, when these 4 patients who is on ERT come with pancreatitis, okay, or any unexplained pain abdomen, okay, unexplained pain abdomen, so this could be pancreatitis. Got it? I'll tell you why. For nephrotic syndrome, we use prednisolone and we use Lasix, that is furosemide. Both are these known to cause pancreatitis. Okay, both of these are known to cause pancreatitis. Second, in case of leukemia, we use L-asparaginase. L-asparaginase is also known to cause pancreatitis. One more is seizure, okay, seizure disorder. Third, in IBD we use ASA, mannose-salicylic acid, that is also known to cause pancreatitis. Fourth, HIV, I already said, stavudine and didanosine, that is known to cause pancreatitis. And important, most important, where I have seen cases, seizure disorder. Seizure disorder, child is on valproate and then child comes with acute pain abdomen, which is not explained, amylase lipase may or may not be elevated. It can cause pancreatitis. Okay, these are the few of the drugs which can cause pancreatitis. In addition to this, we have few more drugs like metronidazole, which can also cause pancreatitis. Okay, but all these are less. But whenever a patient with nephrotic syndrome, leukemia, IBD, HIV, who is on ERT and with seizure comes with unexplained pain abdomen, then you have to work up for pancreatitis also. Okay, few important points are in valproate induced pancreatitis. So usually this drug induced pancreatitis will happen around 4 to weeks after starting drug. Okay, 4 to weeks after starting drug you will get pancreatitis. But in valproate, in case of valproate, it can happen after months to years. That is because a toxic metabolite gets accumulated that will cause pancreatitis. Okay, so treatment of drug induced pancreatitis is good, and actually prognosis is very good when the drug is withheld. So it is very essential to promptly identify drug induced pancreatitis. Next, fourth etiology is systemic diseases, and the most important cause is HUS. Okay, HUS causes, followed by sepsis, then we have Kawasaki disease, and then HSP. These are the 4 main causes, and also we have autoimmune causes. Okay, in autoimmune causes we have one SLE. Okay, we have 2 Crohn's, IBD. These are all known to cause pancreatitis, but it is very less. Okay, I haven't seen any cases so far, but sepsis and HUS, they are known to cause pancreatitis. Coming to metabolic disorders, you have 2 disorders. One is cystic fibrosis. Okay, and second one is hypertriglyceridemia, and third one is hypercalcemia. See, in adults, hypercalcemia and hypertriglyceridemia are known to cause. Okay, they are most common, but in pediatric cases it is very less. Okay, it is very less. Hypertriglyceridemia is most commonly seen in familial hypercholesterolemia syndromes. Okay, familial hypercholesterolemia, and hypercalcemia also can be seen. That's why we see for all these TG levels, we see for calcium levels. Okay, whenever a patient with pancreatitis comes, we work up for all these causes. Gallstones in children is again less. Okay, less frequent, but you'll need to take history of anemia. Okay, because it can occur in hemolytic anemia. You have to see if there is any history of hemolytic anemia or thalassemia or sickle cell anemia. In these patients, you can get gallstones. Okay, next, what are the other miscellaneous causes? Very important, autoimmune pancreatitis, but it is very, very rare. Okay, there are 2 types of autoimmune pancreatitis, type 1 and type 2. Type 1 is most commonly seen in adults. Okay, and in this case IgG4 is elevated. Okay, type 2 is most commonly seen in children. It is very difficult to recognize also, and it diagnose also, and it is very difficult to manage also. But and it is here IgG is normal. That's why it is very difficult to diagnose. So the treatment of acute pancreatitis is steroids, and they respond well. That's why it is necessary to identify this. Okay, then right now the most important cause that is upcoming is genetic causes, because earlier we didn't know that there could be so many genetic causes, but with the advent of new genetic studies, we know that genetic causes, especially SPINK1 mutations. Okay, SPINK1 mutation is known to cause recurrent pancreatitis in children. Then there can be anatomical defect. The most common anatomical defect is pancreatic divisum. Okay, so this pancreatic divisum, but in all cases of pancreatic divisum, you don't have to get this one. Okay, pancreatic divisum means in the 5th to 6th week of intrauterine life. Okay, pancreas has 2 parts. One is the dorsal bud and one more is the ventral bud. These both will fuse. Okay, and then pancreas is formed. But in pancreatic divisum, the malrotation happens, so that's why ventral and dorsal buds are altogether separate. Okay, it's on the opposite sides. Okay, so in this case, in pancreatic divisum, only 10% develop acute pancreatitis. Okay, only 10%. Not everyone should develop. Okay, there could be other anatomical defects like choledochal cyst could be there. There could be some bile duct defects, or could be pancreatic duct defects. Okay, those are also included in anatomical defects. So now moving on to none of the causes. So I have mentioned so many causes right now. Okay, so these are the main headings, and you have got so many causes, and this is a very important question in your UG exams also, in MBBS, in PG also, and during NEET PG also, and in NEET SS also. Most of these things are only asked. Okay, so other 25% are idiopathic. Okay, where you can't identify any cause, and this has poor prognosis, and they'll go into recurrent pancreatitis again and again. Okay, next. So what is the pathogenesis? Why is acute pancreatitis so dangerous? Why is management so important? See, acute pancreatitis, okay, is because of the inflammation in pancreas gland, and pancreas is known as the tiger gland. Okay, that is because pancreas contains all digestive enzymes. So it has ability to digest all cells, all organs also. Okay, so it is very essential that these enzymes are stored in a proper place, and there shouldn't be activation of these enzymes. So when God has created human beings, God has created human body in such a way that these enzymes are not activated in pancreas, they are in inactivated form. And when these pancreatic enzymes go into the duodenum, only then they are activated. Got my point? So what happens in acute pancreatitis? In acute pancreatitis, there is premature activation of these enzymes inside the pancreas only, and that causes inflammation, destruction of pancreas. As simple as that. Okay, so we know that in duodenum there is an enzyme called enterokinase. Okay, enterokinase. In pancreas, okay, this is the pancreas, and in pancreas we have enzymes trypsinogen. Okay, trypsinogen is the main enzyme that is present in pancreas, and it is in inactivated form. Active form is trypsin. Second, we have lipase and amylase. Okay, lipase and amylase both are in activated form. These are the only two enzymes which are already in activated form in pancreas. Okay, now what happens? This trypsinogen is converted into trypsin by this enterokinase in the duodenum. Now this trypsin activates all other enzymes like elastase, phospholipase, even amylase lipase. Okay, so these are activated, and then the digestion process starts. This is normal. Okay, but what happens in this one is, in pancreatitis, is there is premature activation. There is premature activation of this trypsinogen, causing activated trypsin. Once trypsin is activated, it will start digesting all the things that are nearby, and it will cause inflammatory cascade. Okay, and then it will block all these blood vessels because of this chronic inflammation, this acute inflammation, and it will cause pancreatic necrosis. Pancreatic necrosis occurs. Hemorrhage can also occur. Okay, hemorrhagic pancreatitis can also occur, and it causes systemic inflammation. Systemic inflammation. Okay, so this is basically the pathogenesis of pancreatitis. That's why if you identify pancreatitis right in time and you treat, you decrease the inflammation, you give conservative management, then you can have a good outcome. Okay, so there is no infective pathology, anything happening here. It is just the inflammatory process that is happening. So what are the clinical features? How does patient come to you? Patient will be normal, and suddenly he'll develop pain abdomen. Okay, pain abdomen, and this pain abdomen, classic location is epigastrium. Okay, the most common location is epigastrium, followed by right hypochondrium. Okay, there will be a lot of tenderness, there can be guarding also. Okay, and one typical history is pain radiating to the back, and the patient will be he will be leaning forward to avoid this pain. Okay, pain radiating to back, and patient will be leaning forward. Along with this, you can have other complications which we'll also discuss. On signs per abdomen, you will find all these things. You can also have patient in shock. Okay, if the patient is in shock also, you'll have to see. There could be dehydration features. There will be recurrent vomiting also. Okay, pain abdomen, recurrent vomiting also can be seen. Now, what are the few signs which are specific to pancreatitis? They are Cullen's sign. Okay, Cullen's. Second is Bryant sign, Fox sign. Okay, so Cullen's sign is, and Gray Turner sign. Gray Turner is, see, all these are reddish bluish pigmentation. Okay, I think it is a very common question for NEET PG, which is what is Gray Turner sign and Cullen's sign. Okay, so it is reddish bluish discoloration. Okay, Gray Turner's is in the flanks. Cullen's is periumbilical reddish bluish pigmentation. Okay, periumbilical. Bryant sign is near upper thigh. Okay, upper thigh below inguinal ligament, and Fox is in the scrotum. Okay, so these four are signs, but are they specific? No, it can mean other conditions also. Now, why do this reddish black discoloration occurs on abdominal wall? That is because there will be lipase. Okay, lipase from the pancreas which leaks down. Okay, it breaks down RBCs. Okay, and it causes a complex called as methhemalbumin. Okay, this will cause staining. So other conditions also it can occur, like for example ruptured aortic aneurysm. Okay, in ruptured aortic aneurysm we can get all these signs. Okay, any of these signs, and we will also get it in hemorrhagic ascites, and also in splenic rupture. So basically any internal bleeding can cause this. Okay, splenic rupture. So I'm saying this because you can get a question in NEET SS or NEET PG where you'll be given all these differential diagnosis, and it will be, the question will be like in which it is not seen. Okay, or in which it can be seen, and multiple choice can be given. That's why you should keep this in mind. It is not very specific to pancreatitis. In other conditions also it can happen. Okay, so now we'll go to complications. What are complications that can occur, and this complication can present to you as symptoms also. Okay, so we have systemic complication and we have local complication. Local complication is in and around pancreas, and that usually develops after 1 week. Systemic complication happens within 1 week. Okay, most commonly within 48 hours. So we'll go systemized. For example, in CVS, what complication can occur? Shock can occur. Okay, and LV dysfunction can occur. Second, RS, what can occur? ERDS can occur, okay? Pleural effusion can occur. Third, in renal, what can happen? AK can happen, okay? Your creat can increase, your urea can increase, okay? Next, fourth, renal is done, okay? In CNS you can have encephalopathy, which is very rare, okay? And there is something called as, which can be useful for NEET tests, that is posture retinopathy. What is this? This is onset of severe blindness, okay? Severe blindness in acute pancreatitis. It is known as posture retinopathy, okay? Then you can have metabolic complication, that is you can have hyperglycemia. That is because of hyperglycemia is because of endocrine pancreatic dysfunction, okay? And then you can have hypocalcemia, okay? Hypercalcemia is a cause, is an etiology, okay, of acute pancreatitis, whereas hypocalcemia is a manifestation of acute pancreatitis, okay? Next, coming to local causes, okay? In local causes you can have one is pancreatic necrosis, okay? Pancreatic necrosis can be infected necrosis. If it is infected, then we'll have to give antibiotics, okay? Or it can be sterile necrosis. Second is pancreatic abscess, okay? Third is pseudocyst, okay? And you can also have pancreaticopleural fistula. All these are long-term complication, okay? Done? Okay. So that is why it is very important, when symptoms don't improve even after 48 to 78 hours, you will have to do CT, okay? Because there could be some other things that are going on, like there could be pancreatic necrosis which is going on, there could be hemorrhagic pancreatitis, or abscess could have been formed, okay? So to rule out all these things, you need to do CT if the patient doesn't improve after 48 to 72 hours, okay? Now, how do you diagnose and how do you approach the case of pancreatitis? How do you diagnose pancreatitis is very important, because in adults it is very easy to identify, because they'll come with pain, they'll be very cooperative in ultrasound also, and their enzyme levels will be like adult levels, okay? We'll discuss all this, okay? So according, for adults we use modified Atlanta classification, okay? Modified Atlanta, and this criteria says that 2 out of 3 should be available. Similar criteria only we'll use for pediatric, but there the study was conducted by this INSPIRE group, so we should have 2 out of 3 criteria. That is, 1, symptoms which are consistent, okay? Symptoms which are consistent with acute pancreatitis. Second is increased levels of serum amylase and lipase, okay? And how much increase? More than or equal to 3 times the upper limits of normal. And third is radiological finding consistent with acute pancreatitis, okay? So why do they give this 2 out of 3? Why not all 3, or why not 1 out of 3? That is because in small children less than 1 year, they cannot be symptoms also, okay? There need not be symptoms. They can come with feed intolerance. Feed intolerance in a hospitalized child is also one of the known cause of pancreatitis, okay? One of the manifestation of pancreatitis, okay? So feed intolerance also can be there. So it is not consistent with acute pancreatitis. And why is the criteria of amylase and lipase is essential? In some cases, amylase lipase cannot be normal. Sometimes amylase can be, in 10% of the patients, okay? In 10% of the patients, amylase doesn't rise initially. That's why we'll see in the next few minutes that how lipase is more important than amylase, okay? And third, radiological features couldn't be there because you're doing USG whole abdomen, and in pancreatitis there will be a lot of gas because it can cause ileus, okay? So this ileus can cause a lot of gas, so pancreas is obscured and you won't be having a proper view at pancreas. So that time you'll have to see at other criteria. That's why 2 out of 3 must be present to call it as pancreatitis. Now, what about these levels of enzymes, amylase and lipase, which is better and what, okay? So normal levels of lipase is 0 to 160, okay? And normal levels of amylase is 30 to 110. Now this is adult level. So how much should be increased? So lipase should be more than 480, that is more than 3 times upper limit of normal, okay? And for amylase it is more than 330, okay? So this is a crude cutoff, okay? So if lipase and amylase, we'll see how the graph of lipase and amylase looks like, okay? So we'll see first with amylase. So we'll see with lipase only, okay? If this is lipase and here acute pancreatitis inflammation has started, so lipase will start increasing after 4 to 6 hours, okay? After 4 to 6 hours it will start increasing. Peak is reached around 24 hours and it will stay till almost 1 week. Got it? So lipase is late to rise and it is late to fall down. So if a patient comes after 3 to 4 days, doing amylase is of no use. You have to go for lipase. And amylase MILS will start increasing within 2 to 3 hours. Okay, 2 to 3 hours it will increase. It will reach peak at 12 hours. Okay, and then it will start come down at 3 to 5 days only. Okay, so this is the peak for MILS. Now, is there any other condition where lipase can increase? Yes, there are two important conditions where lipase can be falsely increased. Okay, false increase in lipase. That is, one is renal failure. That is because lipase is excreted through kidney. So if kidney doesn't excrete, then in renal failure lipase can be increased. Second is intestinal perforation. That is because during intestinal perforation there can be leakage of lipase enzyme that will cause increased lipase levels in blood. Okay, but what about MILS? Is MILS so good? Not at all. In MILS can be increased in many conditions. Okay, MILS can be increased in, one is intestinal perforation. Okay, second is it can be increased in intestinal obstruction also. Okay, in intestinal obstruction. Third is mesenteric ischemia. Okay, and we have seen one more case where MILS is increased in mumps. Okay, so there are many conditions where MILS can be increased. So when you see for specificity and sensitivity, okay, first we'll say sensitivity and specificity. Here also sensitivity and specificity. Sensitivity of lipase is very high. It is almost equal to 95%. Okay, specificity is also very high. It is almost 90 to 92%. Okay, sometimes even 100. Some books also mention it as 100%, but it can come close up to 90 to 97%. Okay, so both sensitivity is also high and specificity is also high. But for MILS, sensitivity is high, specificity is low. Okay, this is one major difference. Now, if you ask me which is better, is lipase better or MILS better? In pediatric population, lipase is always better. In addition to above causes, the important thing is lipase will reach adult levels at 1 year of age. Okay, but MILS will reach adult levels at adolescent only. Okay, so that's why lipase, which reaches adult levels at 1 year of age, is a better predictor of pancreatitis. So if you ask me what is the investigation of choice, if in any exam, NEET PG or maybe NEET SS or some other exam, which is the investigation of choice for pancreatitis, the answer is serum lipase levels. That is the investigation of choice. But what is the gold standard? The answer is there is no gold standard investigation. There is no gold standard investigation for pancreatitis. The investigation choice is serum lipase. So we have seen two enzymes, that is lipase and MILS. Are there new enzymes which are coming up? Yes, there are new enzymes. One is pancreatic ribonuclease. Okay, I don't know what is the application right now. We are not using in our setup. Pancreatic ribonuclease, it is useful for necrotic pancreatitis. Okay, and second is TAP. That is one more is immunoreactive trypsinogen. Okay, immunoreactive trypsinogen. This has application especially in it is a biomarker of cystic fibrosis. Okay, biomarker of cystic fibrosis. Second is pancreatic ribonuclease, and third is TAP. Okay, and this urine levels of TAP. Okay, that is used in diagnosis of pancreatitis. Okay, but it is all upcoming. Okay, next, what does CBC tell us? CBC, there will be increased TLC levels. Okay, so increased TLC, hyperleukocytosis is seen in pancreatitis. Okay, what about okay, next is KFT. KFT can tell you whether the patient is going to shock or whether there is dehydration. Okay, you will have to see at urea create levels. Okay, AB is also useful. It will tell you whether the patient is going to shock. You have to see at lactic acidosis. Okay, two important things to comment: AST and LDH, if they are increased, that can be suggestive of necrosis. Okay, it is suggestive of tissue necrosis. So in a setting of pancreatitis, you will think of pancreatic necrosis. And ALT, if it is elevated more than 3 times of upper limit of normal, then it can be an indication of biliary pancreatitis. Okay, biliary pancreatitis, which is a very rare entity in pediatrics, very rare. Okay, so coming to imaging. Okay, so what are the imaging? So initially the imaging which we do is USG. Okay, USG whole abdomen, but it will be positive in only 1/3 of the patient. Only in 1/3 patients it will be positive, because in the rest of the cases there will be increased gas shadow, so pancreas will be obscured. Okay, and what you'll see is bulky pancreas. That is the most common finding that you get. Chest X-ray you will do to see for ARDS, or you will do for pleural effusion. Okay, third is X-ray abdomen. X-ray abdomen you'll get 2 signs in pancreatitis, but it is very common in adults, but pediatric patient it is very difficult to differentiate also. One is colon cutoff sign. Okay, and another is sentinel loop sign. This is important for NEET PG exam, where this question is asked in surgery. Colon cutoff sign means this is your transverse colon and this is your descending colon. This splenic flexure is there. No, here you can see a prominent you can see gas shadow still here, okay, but you can't see here because here the inflamed pancreas will be obscuring this, okay. So that's why here you will be seeing prominent gas shadows, here you won't be seeing much, okay. That is colon cutoff sign. Next, CT abdomen. CT abdomen is indicated if the patient deteriorates or there are any complications that you might suspect, okay. CT abdomen, we use Balthazar severity grading, okay. Balthazar CT severity score, okay. Next, MRCP initially is not planned. After acute attack settles, then to look for cause of pancreatitis, that we use MRCP. It is very good for identifying anatomical defects and gallstone pathology, okay. Gallstones, if they are there, it is also good. Okay, so we have gone through how to diagnose pancreatitis, what are the criteria in INSPIRE criteria, what are the enzymes that are important, okay. Then we have gone through all these investigations and imaging. So now we are coming to management. Pancreatitis management is very easy if you know how to diagnose. One is done. Second is the most important management of pancreatitis lies in IV fluid, that is hydration, okay. So the first question that comes to everyone's mind is what IV fluid should we give and how much to be given, okay. I'm touching this first because this is more important, okay. See, pancreatitis is a state of like capillary, there will be capillary leak, there will be dehydration, there will be vomiting, that's why also patient can go into shock, okay. There will be defects in pancreatic microcirculation, the pancreas can go into necrosis if there is hypoxia or tissue damage. Also it can cause complications elsewhere in the body also. So main thing is the hemodynamic stability should be maintained. So if a patient comes with shock, definitely you have to give IV bolus of 10 to 20 ml per kg. This is the recommendation, okay, 10 to 20 ml per kg. And after that you have to start patient on hydration or IV fluids. Now which IV fluids? IV fluid choice is, in some studies it is mentioned RL is better than NS, okay, but in some studies it is mentioned that RL is equal to NS, there is no added benefit of NS. So you can go with either of them. But one thing to note is, if the cause of pancreatitis is hypercalcemia, then you will avoid, okay. Then you will avoid RL because RL has 3 milliequivalents per liter of calcium in it, okay. And how much IV fluids to give? Normal is 1.5 to 2 times, okay. This is for 24 to 48 hours, okay, because that time you will be keeping patient NP also, and there is added fluid requirement also, okay. So this is about IV fluids. Second, you will do vital monitoring, okay. See, pancreatitis management is mainly medical management unless there are complications, okay, where you'll go surgical. In medical management, one is you'll see the vitals, okay. You'll first is about the vitals and hydration part. So vitals, you'll be monitoring vitals regularly. You'll be doing ABG also, okay. You'll be putting patient on O2, okay. Oxygen is important, okay. And then you will also put monitoring patient for shock, and then if shock is there, you will be treating it with 10 to 20 ml kg per kg bolus also, okay. And NG feeds, what is the recommendation right now? You should start NG feeds within 24 hours, okay. That is the current. You should start early enteral feeds, okay. It was very old concept that we have to keep patient NPO for long time and all. No, now early enteral feeds are shown to benefit the patient. Next, is there any role of antibiotics? Yes, only if there is pancreatic necrosis, okay. Pancreatic necrosis is there, or any other infected pancreatitis is there, okay, or pancreatic abscess is there, then only we'll go for antibiotics, or the patient is worsening after 48 to 72 hours. Otherwise it is mainly conservative only. Next, important management is for pain management. Ideally we can use morphine or pethidine, okay. Initially we'll use first lines, like we'll use in our setting, we use usually PCM, tramadol we'll use, okay, but opioids are the choice. Morphine is known to cause sphincter of auditory dysfunction, so many experts they avoid morphine, but pethidine is one more good choice, okay, pethidine or meperidine. Next, complications. Management of complications is also important. I have told complications, these will be managed accordingly. There is nothing different in that. Now, what are the surgical management indications? One is there is infected pancreatitis for debridement, okay. If there is necrosis, then you will have to debridement. For that, there is one indication. Second is traumatic pancreatitis, okay. Suppose you want to correct the bile duct injury which is happening because of traumatic pancreatitis, that is there. Third is if there are gallstones, okay, you can do ERCP and then you can remove gallstones, or you can do cholecystectomy, okay. And fourth is pseudocyst. Once pseudocyst is formed, if pseudocyst is causing something, usually pseudocyst will resolve, okay. So pseudocyst is it is a peripancreatic collection which is fold. Okay, it is a walled off peripancreatic collection with a proper wall. Okay, which consists of secretions which are rich in pancreatic enzymes and blood and other tissues. Okay, so usually this will resolve in pediatric age group. If it is very big and it is causing distress, then we'll go for surgical approach. In adults, we'll do cystogastrostomy. Okay, we'll open this cyst into stomach. Okay, to drain. In pediatric cases, most of the pseudocysts they will subside. So few important things I think I should discuss is, one is hypertriglyceridemia. Even though hypertriglyceridemia pancreatitis is very rare, but when you do hypertriglyceridemia pancreatitis, one important thing you have to remember is this amylase assay. Okay, when you do amylase levels, it can be normal. That is because triglycerides they will interfere. Okay, they will interfere with this amylase and it will cause a false low reading in amylase. Also, hypertriglyceridemia requires mention because in hypertriglyceridemic pancreatitis, okay, why this one occurs, like pancreatitis occurs, is because there is something called as lipoprotein lipase. Okay, lipoprotein lipase. This lipoprotein lipase will be breaking down triglycerides, and this triglycerides will break down into free fatty acids, which cause free radical injury. Okay. Now, when there is pancreatitis, on the setting of pancreatitis, if this activation increases, then there will be more free acids that are formed. This more free acids will attack on pancreas. In pancreas, there will be lipase, lipoprotein lipase, that will again degrade triglycerides. So this vicious cycle will continue. So it is very very important that you treat this in time, identify this in time, and the treatment is plasmapheresis. Okay, we'll give plasmapheresis and IV insulin. These are the two treatment modalities we use in pediatric age group. Okay. So I think I have covered almost everything regarding acute pancreatitis. Okay, so I hope this series, this video has helped you. I have discussed it from student point of view also and from clinician point of view also. So two important things, again, take home message for pancreatitis is, one is early identification, okay, and management. Okay, early identification and management, and avoiding complication and treatment of prompt complications. And second is identifying the etiology. These two forms the hallmark of pancreatitis.